Hello, Rebecca. Hi, Chris.
Hello.
Thanks for agreeing to start us off today.
I didn't think I could spend 5 minutes, and then I was reading everyone's bios. I'm like, some of these bios could be 5 minutes.
Oh, okay. Yeah.
Just a very impressive panel of people that are coming. So
there you go. You're totally right. It looks like our first three presenters are all on, so we can start. I'll start by just saying hello to everybody who's on the call and welcome to our monthly CMDA meeting. Today is Tuesday, March 7th. I'm Dr. Singh Pallet, the president of CMDA. And we have several speakers today, starting with Drs. Chris Horton, Rebecca Jackson, and Raj Rai. And they're going to give us an overview of the upcoming CMDA annual conference. This is the conference that's a full day of CME. It's going to be on April 28th. It's on a Friday. It's available for in-person or virtual attendance. And the early bird rate expires, I forget which date, but it's coming up. So you better sign up and get registered. You can go to our website at www.cmda.us and register for the annual conference. But why don't we go ahead? I'll go ahead and let Chris, Rebecca, and Raj talk about what's coming up at this conference.
I guess I'm up first. Hi, everyone. It's Chris Horton. I really want to thank everyone for being on the call and thank all of you members for making Colorado Medical Directors Association one of the largest in the country. Each year, we work really hard to make our annual conference better than last year. And I think we're going to succeed this year. Also, you can achieve 7.75 credit hours of CME for only $90 as a member. So that's really, really low cost. Not to mention you get to join all of your members in community and meet in person. So it's really a great opportunity. This year, our keynote speaker is actually an alum from Colorado, Dr. Michael Wasserman. And he is currently the chair for Public Policy Committee for the California Association of Long-Term Care Medicine. And he's also a member of the National Academy of Sciences Framework for Equitable Allocation of Vaccine for the Novel Coronavirus Committee. And he's a member of California's Community Vaccine Advisory Committee. Very excited to have him. He is going to discuss the missing ingredient in nursing home quality. I'm not going to tell you what it is, but he is going to be a great speaker. So we're very excited to have him. In addition, we're going to have a talk by Matthew Griffin on COPD. And he will identify 2 indications for escalating current COPD.
We did them at the hospital.
treatment.
Yeah. So we try to.
And we're really honored to partner with several organizations, but Colorado Public Department of Health, Elaine McManus is going to identify current public health policies. So I think this is huge. It's important for everyone in attending, whether you're an administrator, director of nursing, provider, medical director. It's going to be really helpful information. That's about all I have. So I'm going to pass it on to whoever is next.
I think I'm it. Tag, I'm it. My name is Rebecca. I'm a geriatrician up in Fort Collins. I'm happy to be here today talking about our annual conference. I love CMDA and AMDA. That's been at my professional home. And I think this, it's nice to be able to meet in person and be together again. And this year is going to be, I think, a great year. We just highlighted that, CDPHE is going to be there. And I think one of the unique things about CMDA is that we have really great relationships with our community members. And that is a unique thing, that we have people from the state that come and call into our monthly meetings and attend our annual conference. So it'll be great to have them there. And another person is Dr. Christine LaRocca. She's a medical director from Telligen, our quality improvement organization. And she always is there presenting and updating on what they're doing to support the long-term care setting for quality improvement. Dr. Carrie Levy will be presenting again this year. She's presented in the past, and she holds many very impressive titles, including being a past AMDA president. She is currently the division head of geriatric medicine and director of the Multidisciplinary Center on Aging at the University of Colorado. And we really have been working hard to partner with them this year. And she will be presenting on the always interesting subject of full code in the nursing home. So another university representation we have is Dr. Stevens Lapsey. She is a physical therapist and director of rehab science program, as well as the section director for research and development in the PT program at the University of Colorado as well. She's going to be presenting on high intensity rehab, which we've covered in the past, but this will be a good update because we haven't talked about it in quite some time. So, and then finally, I was just going to cover Dr. Alan Horowitz will be presenting, Mr. Alan Horowitz. He's a lawyer, actually, who will be presenting on medical errors and how to avoid liability. He's worked with the United States Department of Health and Human Services. He's also litigated on behalf of the CMS. So it'll be really interesting to hear what he has to say. So those are some of the things that I was going to highlight, and I'll pass it to Raj.
Thanks, Rebecca. Raj Rai, wound care physician. Good to be on the call with you all. I'll say a couple of things just about this conference. You know, to echo what Chris and Rebecca said, you know, this is you think about CMDA and all the work that goes into it, and this conference that comes about, it's really the culmination of a lot of people's efforts to try to highlight some of the relevant or the most relevant issues that are present for for all of us that are providing care in the community. And so, you know, if you look at it in the years past, it's been, you know, very focused, and this year being able to spread that out a little bit more over the course of several really amazing speakers is you know, it's really a way to come in together and get a ton of really valuable information that can help you in your the care that you provide. And so I'll kind of briefly go over some of the stuff that you'll get an opportunity to be exposed to. For starters, the fall prevention panel, which has been there in years past, and always a good sort of pro quo with panelists that are present. And after that, Erin Beignet, who's a nurse, has done a lot of work in trying to figure out a problem that's very near and dear to all of us, which is the shortage and in the post-acute space, and how we can address that to make the work environment a better place, even to attract more talent to this to our communities. Following that, Dr. Heather Heiser from the University of Colorado as well has spent some time working on movement disorders. Tremendous topic that she's going to be presenting, and then followed by Dr. Lindenberg, who will do a really in-depth discussion on deprescribing, which I know is very important to all of us and very relevant to the care that we provide there. So, excuse me. Following that, both Allison and Dr. Eber will be presenting on the pearls from the day. There's going to be a lot of great information, so you don't want to miss that. It's really just a good way to summarize all the efforts that everybody puts together. And in years past, it's just been a really, really good opportunity for everyone to partake in. So yeah, I certainly encourage everybody to come and try to be a part of this. It's just a panel of tremendous speakers, and yeah, looking forward to seeing you all.
Thank you. What a great overview of that day. Obviously, there are a lot of different things going on, and I echo everything that all three of you said. If anyone has any questions about the conference, please go ahead and ask us now or put it in the chat box. And certainly we encourage you to go ahead and go to cmda.us and get yourself registered. Our next speaker today is Dr. Elizabeth Bloemen, geriatrician at the University of Colorado. And she will be presenting on vulnerable elder services, protection, and advocacy. Elizabeth, do you want to share your screen from your computer?
Yeah, that would be great. Let me pull up my slides. Let me know if you can see them in the full view.
Yes, thank you.
Okay, great. Yeah, so thanks so much for having me. I'm one of the geriatrics fellows at University of Colorado this year, and I help run our elder abuse consult team. So we started this team about a little over 2 years ago, and we see patients in the hospital and in the emergency room where there's concerns for elder abuse and neglect. And so thought I would just let you guys know a little bit about us and what we do. So just want to, let me see if I could get my slides to advance. Okay, great. So I think it helps to just go over the elder abuse definition, because I think facilities get a bad rap in the lay media. I think that's where most people think of elder abuse happening, but elder abuse is really any abusive situation where there's an expectation of trust that can cause or create a risk of harm for older adults. There's of course the 5 subtypes that we're all familiar with, including physical, psychological, sexual, financial abuse, and neglect. And usually when we see cases, there are multiple types of abuse going on at once. And very often people have experienced other types of abuse earlier in life as well. We know that 10% of community dwelling older adults experience elder abuse each year, and 20% of our nursing home residents experience elder abuse each year. But I think this is where the lay media doesn't do a great job. This is mostly a family violence problem. So 9 out of 10 incidents involve family members as perpetrators. And we know that even in the facility setting, often there's like ongoing financial abuse or other abuse that's happening once patients are placed. And so this is really more of a family violence problem than I think it gets the credit for in the general population. In Colorado, we see quite a bit of elder abuse. It's interesting, these numbers actually match the same reporting that we see for child protective services. So about the same number of cases in each. I think we're all very familiar though that APS is massively understaffed compared to CPS, which is not robustly staffed either. But we know that for every case of elder abuse that we actually identify, there's about 24 cases going on that no one ever knows about. So it's a really big problem, and it's a big problem that we think physicians should play a more active role in. And this is similar to where child abuse was 60 years ago. And so we have taken a lot of lessons from our child protection team. Fun fact, child protection as a field really started at the University of Colorado. Dr. Henry Kemp started the field back in the late 1950s, early 1960s. And they're a huge partner of ours. So if anyone's familiar with that team, they provide child abuse consultations at Children's Hospital and Denver Health. And I worked very closely with an investigator named Tony Rosen out at Weill Cornell, who said, hey, we should apply this same idea to older adults. And so they started the first team back in 2017. And then we applied for Victim of Crime Act funding and received funding back in 2020. Our funding started in 2021. We were renewed, so we have funding through 2024, thankfully. We have 2 arms of our team right now. We're at University Hospital and we're also at Denver Health. So you might see us at both locations. And what we basically do is, like, I like to say it's just geriatrics on steroids. It's a very thorough history, physical exam, a lot of time getting to know people, getting to know their families. We help liaise with APS and police, try to be that point person for them in the hospital, and also try to connect them to any providers out of the hospital so that there can be more coordinated care for our patients when they leave. And we work on what we used to call safety planning, but I like harm reduction planning a little bit better. I think that's more realistic and usually more patient-centered than trying to eliminate the risk altogether. And one of the big things we focus on is connecting to that primary care medical home, and whether that be the primary care medical home in a facility or in the community. We try to make sure that they're aware of what's going on, particularly when our patients do the SAR to back home transition. I feel like that's where a lot of things can get lost. So we want to make sure if someone does go to a SAR, we continue to follow them until they're back home to make sure everyone's in the loop of what's going on. And then we also do staffing. So after we see patients in the hospital on Thursday afternoons for our patients where we have a moderate or high concern for abuse, We staff them with our entire team. We have 4 providers, an emergency medicine doc, forensic nurses, dedicated social worker. If needed, we have a civil attorney, and we all talk about our case and what we found. We also invite APS and law enforcement to that as well. And anyone else who would like to join and is part of that patient's care is welcome. So we have the primary team join. Sometimes we've had PCP offices join others, and it really allows for a lot of open communication and trying to figure out how do we best serve this patient. So to date, we have seen this is a little bit outdated. This is about a month ago, and our consult numbers have picked up significantly. So I think we're almost hitting 200. I think we're at like the 190 mark or 195 mark now of consults in the last 2 years. Mostly at university, Denver Health has been a little bit slower for a lot of systemic reasons. And we're mostly being called by medicine services right now. So we're not getting like the high risk surgical cases. It's mostly medicine. We do see people aged 40 and above who could be considered vulnerable. So we've seen 6 patients who are under the age of 60. Almost all of those have been people with intellectual or developmental delay or cerebral palsy. We had 1 early onset dementia. And so we will see patients younger as needed. We see a fair amount of, it's a pretty balanced population for a geriatric population, 63% are female. I see a lot of veterans because we're right next door to the VA. So we get all the ambulance cases, which I love, of course. And then most of our patients have a dementia diagnosis before we see them. Others are diagnosed during the admission. And 63% of our cases are community dwelling at the time of the admission. We screen for co-occurring family violence. So we have identified 5 co-occurring cases of child abuse, and CPS was appropriately involved in those cases. Some also cases of intimate partner violence of younger people and animal abuse. We make reports to APS when we have a concern for self-neglect as well as abuse. So about 73% of our cases we report. The rest we say there's no concern here. It's a family under stress or things that we can intervene on that we don't need APS involved. We only report to law enforcement if we're concerned for abuse or neglect by a caregiver. So that's about 65% of our cases. And we do report to CDPHE if it's a facility case where we have a high enough concern and if the facility hasn't already reported. And the vast majority of the time, the facility has already reported. So it's been only like 19% of our facility cases have we reported. We are mostly right now called for physical abuse and neglect, but then when our team gets involved, we often find other abuse typologies, including verbal abuse and financial. We do a lot of, our social worker is amazing and she does a lot of counseling and care coordination for these families. We also have a nurse practitioner who's kind of our point person and calling the facilities and interacting with mostly directors of nursing as needed. And then we try to help with discharge planning. So if they are going to go to a facility, a lot of times that is a medium, I'll say a medium level outcome for our patients. Some patients really want to go to facilities. Sometimes there's just no other option. But a lot of times placement is what we are looking for in these cases. So anytime we have a facility case, we always contact preferably the director of nursing, try to have a conversation about what's already been going on, what our level of concern is, and usually they've already reported everything's been taken care of. But if not, then we will file a CDPHE report. I will say of all the facility cases we've seen, we've only had 1 that met high suspicion. In that case was actually an unlicensed assisted living facility that was also practicing very predatory behaviors. And so we've never had a skilled nursing facility where we were very concerned. And a lot of times when we are called for facility cases, it's really us kind of managing patient and families' expectations of what's realistic in different care settings. So we've been called on several cases where they expect it to be the same as like an acute care hospital and that same level of care, and that is just not realistic. So we try to kind of do a little bit of teaching, being providers who work across settings and having a better understanding of that, of what's going on. But that's a little bit about us in a nutshell. This is my contact information. If you guys ever have a case with us or want to learn more about our team, please feel free to email me. And if you guys have any feedback for us of how we could work better with our facilities, please let me know. So I'll stop sharing and I'll put this in the chat too so people can copy it out of there.
Thank you very much. Thanks, Dr. Bloemen. Does anyone have any questions?
I do. I'm just curious whether you do referrals for guardianship as part of that process?
Yeah, we are very spoiled at University Hospital and we have a guardianship social worker. But we, as a team, do a lot of the capacity assessments for these patients. We find the primary teams are really uncomfortable doing capacity assessments in these situations. So our team will do the capacity assessment. Pretty much in all of our cases, we do a version of a capacity assessment, whether that's just for discharge planning, whether that's for other bigger decisions, or whether it's for guardianship. But we have a fair amount of guardianship cases. Yeah.
And if a community facility had some question as to whether one of their elders was having in an abuse situation, what do you recommend we would do from there, besides notifying the authorities?
Yeah, I think notifying the authorities is great. I mean, I think ombudsmen are a great resource that we don't have like on the community side of things. They can be very helpful. We are happy to be a resource. We've been approved through legal and everything to do outside consult. So if you guys have a particularly sticky case that you'd like us to weigh in, let me know. We have like somewhat limited bandwidth for that right now, but we're hoping to get more, especially when I join faculty soon. Thank you, Carrie, for hiring me. And so we'll have a little bit more bandwidth in the coming years. Right now, like if there's a particularly sticky case, we're happy to help and give some guidance on what to do.
Yes, I was going to put that in the chat, but I'll just say we're very excited to have Dr. Bloemen join the faculty come this summer. So you can email her now and you can email her later and she'll still be around even though she's a fellow. Yeah, just great news for us.
And along those lines, how did you get involved in this project in the first place, especially as a fellow?
Yes. It's kind of a weird story. So I actually worked with elder abuse far before medical school. I did my master's in public health and aging and was interested in elder abuse and worked at Cornell with Tony Rosen before he started his team. And then I came back home for med school in residency and knew I wanted to stick around. So I was an intern when we applied for the VOCA funding and I co-wrote it with Dan Lindbergh, one of our ER doctors. So I started the team as a second-year resident and have been working on it kind of in my free time since. So this is kind of my passion project.
All that free time you have as a resident, right?
Yes.
It's really tremendous.
Thank you.
Very good. Thank you so much for sharing and telling us about this project.
Thank you for having us.
Well, Chad,
And it looks like you're in VA clinic. Have a good VA clinic.
Thank you.
How could you tell?
I can tell by the walls. I recognize those walls. So, yep.
Thank you. Our next speaker is Chad Fear with the CDPHE.
Good afternoon. I just have a few things to share with you. Just kind of some housekeeping for ourselves. Wanted to let you know that we are still working on the backlog of recertification surveys and have a goal to reduce that number by half by September 30th. So we're looking at getting about another 28 facilities up to date or current with their survey schedule, while keeping those that are current, maintaining those so that they're not falling into the backlog. So it's a daunting task to say the least, but it is certainly a major priority for us. Let's see, I just want to let you know that we've had a few more situations of immediate jeopardy. I think since the last time we met, and these concerns were related to smoking, risk, endangerment while smoking, elopement, and a couple situations where CPR was withheld when there was an advanced directive in place for resuscitation. Want to remind everyone that CMS is doing psychotropic drug audits, looking at MDS information and doing audits of the use of psychotropic medications. So, you know, we need to make sure that there's an appropriate diagnosis when psychotropic medications are being used. A little bit about recent findings. You know, the concerns that we've identified, and when you compare that to the concerns identified nationwide, they're very, very similar. And we're seeing, you know, patterns of citations for accident hazards, infection control, pressure wounds, abuse, dependent care, ADLs for dependent residents, respiratory, dementia, dignity activities. Those are kind of our more frequently cited citations. We see some citations that are on the rise as well. And really these seem to be, you know, maybe associated with some of the revisions to the state operations manual that occurred in October. But looking at citations related to visitation, staffing, behavior health, trauma, informed care. Again, looking at the unnecessary psychotropic medications, antibiotic stewardship, and the having an infection preventionist. One area that is on that list that I've singled out here at the end, I wanted to just circle back to the issue of quality assurance and performance improvement. And more and more, there's going to be consideration for citing deficient practice associated with these functions. There'll be a look at patterns of past non-compliance in same or similar care areas, you know, which really underlines the importance of self-identifying concerns, creating performance improvement plans, implementing and evaluating the effectiveness of these plans, and revising where needed. So it really kind of becomes fundamental to the facility's, you know, process of performance improvement. And it is, you know, one of those views that we're going to have to take when we look at the processes that are in place and consider whether that quality assurance and performance improvement process was indeed effective. If there aren't any questions, that's what I have for you today.
Thank you. Thanks, Chad. Always appreciate your updates. Do you have any guidance or for our facilities or advice about the abuse citation specifically, especially since Dr. Bloemen just gave her presentation?
You know, that is it is a difficult area that we continue to, you know, evolve our design around how we see things when we go out on survey, the education that we're providing to surveyors. I think over the last so many years, there's been an absolute that's been created in terms of looking at abusive situations. And, you know, the one that really just floats to the top right away is when you have a resident-to-resident abuse situation happen. And, you know, I think we need to apply some reason to when we look at these situations. The absolute over the past couple of years has certainly been, if it happened, then it's deficient practice. And I think we need to spend a little bit more time completely understanding the circumstances surrounding the altercation. You know, particularly if it's something that wasn't necessarily predictable by the facility, and therefore there may or may not have been, you know, those anticipatory interventions in place. There are some things that do create situations that are absolute. And then when we take a look and we see the existence of harm, that's going to increase the likelihood that there could be deficient practice. But we definitely want to apply as much reason as we possibly can within the confines of the direction that we received from CMS around, the kind of the black and white nature of those situations.
Very good. Thanks, Chad. Does anyone have a question for Chad? Well, we appreciate it. Thank you so much. Thank you for your great work at the CDPHE. Our next speaker is with CHCA, Jenny Albertson. Go ahead, Jenny.
We must have sound. Okay. I'll give as brief an update as I can, but of course, as usual, there's a lot of information that is pertinent to what you all do every day. So I want to make sure you're up and up. First of all, we did have an open door forum call with CMS about the end of the 3-day qualifying stay waiver. You probably were intimately aware of this during the COVID circumstance. And as of May 11th, they will be ending that waiver. And so we will again return to the need for a 3-day midnight or 3 midnight qualifying hospital stay for anyone to receive their post-acute benefits under Medicare. That will resume on May 12th. The clarification we asked for on the call was about those who were already covered under a waiver stay at that date. We were curious as to whether we would have to send people back to the hospital to then qualify, and a big mess, obviously. So they are doing their best to make sure that does not happen. If a person who was covered under the waiver discharges to the hospital for an interrupted stay, they would still be covered under the waiver if they meet the interrupted stay requirements for the 3 maximum hospitalization days in the midst of that, but they don't have to go out and requalify to continue a stay. So I hope that's clear as mud. They will also be ending the 60-day wellness period waiver that we've had. I'll get to that in just a moment. I thought this was interesting for you to note, and I will have these slides to you. We thought that the 3-day stay was simply red tape, and that it probably does not benefit our delivery of care in terms of care transitions. And it so happens that federal analysis during this period of suspending the 3 midnight rule, they did not find any declines in levels of care or increases in bad outcomes, or even a lengthening of nursing home stays. So it's not even increasing cost to Medicare to eliminate this 3 midnight stay. We hope that that will then propel us forward to something we've been advocating for years, which is the elimination of the 3 midnight rule. You and I both know that it more often than not results in observation stays and juggling all of the appeals and whatnot around qualifying for Med-A coverage. And it actually has even gone to the level of some state level Supreme Court rulings. So it's just a big waste of money and time. 60-day wellness period. So you probably are already aware of this, but just to clarify, everybody comes with their 100-day benefit. If they exhaust their 100-day benefit under Medicare primary, this is not if they have a Medicare replacement plan, it's Medicare primary. They have to have a 60-day period where they do not access that same benefit. If they reach an exhaustion point, they have to have 60 days to renew it. It's an unfortunate rule, given that people that are acute enough to need a hospitalization and a post-acute are often bounce back situations. So you and I probably would conjecture that this doesn't benefit anyone's level of care either, but they are returning to it as of May 12th. If benefits exhaust prior to May 11th, they're going to automatically reset May 12th to their full 100 days. They don't have to have the 60-day break. So they're not going to be asking us to track the people that were covered under waivers and did they have enough days between or any of that business. It's just going to automatically reset on the 12th. And then just a quick side note, because this comes up a lot when we talk about the PHE ending, the NHSN reporting is not tied to the PHE. So our reporting of vaccination and all the routine reporting that we do around COVID is going to continue till at least December 31st, 2024, because that's under a separate edict. So, and likewise, the EM resource reporting that we do at the state level is expected to continue. Quick note about something you've probably seen in the news. In fact, Senator Grassley just went on the media circuit about this as well. So it's staying bubbled up. CMS is promoting a new reporting process for ownership transparency. You've probably heard a lot about this since the White House proposed this in the presidential speech 2 times ago. His initial speech talked about private equity firms and how there's a correlation between private equity ownership involvement in nursing homes and a decrease in quality. It just so happens that this is kind of a red herring in terms of where we should be looking for quality improvement, because less than 5% of nursing homes are actually owned by private equity firms. So this is not going to affect that many ownerships, and 12% are owned by a REIT, which is a real estate investment trust, which they're also lumping this together when they talk about it in the media. So I just wanted to put that out there so that you know that this is not like we're biting off a big horrible thing that's going on behind the scenes in our industry. It's actually already transparent as well, because we report changes of ownership at the state level. That is all very publicly reported in addition to CMS. So they're just asking for it to be put onto Nursing Home Compare. That's basically the only change that would be implemented, and it's exclusively to inform the consumer when they decide which SNF to choose. FYI, if you didn't see the portal message from CDPHE, any state-funded staffing help that we've had access to over COVID is going to end at the end of this month. So when people are in outbreak, they're in crisis staffing, or they're on the verge of having to actually discharge residents because they can't provide the level of care that is warranted for their acuity based on staffing, we've had the ability to ask for emergency staffing help from CDPHE. Now, it's not always an overnight help. Sometimes it takes a while for them to get a contracted person in, or multiple people. But that will end as of March 31st. Hopefully it ends with the demise of COVID case rates. We'll just see. Also, the state level COVID public health order has ended already, but you may have noticed that nothing changed, and that's because the Board of Health adopted most of the public health order things that are still pertinent to COVID mitigation directly into an emergency rule set. So in April, the Board of Health will again review this emergency rule situation to see if they need to continue it, build it into permanent rule. And the department is in the midst of coming up with what they think needs to be made permanent and recommending that to the Board of Health at that date. I'll be on there as a fly on the wall in case any of you want to know what gets covered in that meeting. I'll make sure that I continue to update our membership about that. These are the things that are open for discussion in the emergency rule. It's the COVID disease mitigation practices, vaccination requirements around COVID, treatment plans for particular health facility licenses, meaning nursing homes and I believe hospitals, and then ongoing hospital data reporting. This came out in JAMA. I thought it would be of interest to you all that our population of seniors 65 and older within their study from 2011 to 2019 increased by 28.2%. This is well in advance of the silver tsunami that we are all anticipating. But I wanted to show you that JAMA is suspecting that with the decline in nursing home bed volume, we will not be able to meet the needs of the people that fall into the age category that is most likely to warrant long-term care. So there are data points being put out there. Whether that will impact policy, I don't know. But we all need to be promoting increased funding of some sort so that we can continue to provide this level of care. I thought this was encouraging. Our rehab that we provided during COVID actually did not really decline much, and they attribute most of that decline to the drop in group therapy during the pandemic. So I thought that was a nice pat on the back that got publicized by this group from Hebrew Senior Life and Harvard Medical School, multi-state data, and it was from October 2020 to March 2021. And we also find in their study that we admitted patients with a much greater burden of cognitive impairment and higher mortality risk. So in the midst of that, we continued to provide rehab in SNFs, and I just thought that was nice to have some positive out there. And in terms of challenges we are admitting, 85% of our nursing home residents are now shown to have a mental and behavioral health diagnosis. This is a recent release from University of Chicago about behavioral health needs in SNF. And it's no surprise to any of us that those who come to us with behavioral and mental health needs likely are also coming to us with an increase in morbidity risks and severe conditions because they cannot opt for at-home care. And that's why they come to us. FYI, this is getting close to my end here. Thank you for the amount of time you've given me today. I have submitted a couple of grants on behalf of our members, and I would encourage you to collaborate with your leadership teams at your communities to make sure they take advantage of these, hopefully when they are approved. It would start in July. This is to get back some of the civil money penalty funds that we have been paying in the midst of COVID, and also just historically, there's approximately $13 million sitting in those coffers at the state level here. And they can only be utilized in the form of grants that contribute back to education and improvement of resident quality of life. And so we have asked for free trauma-informed care education and certification courses for at least half the nursing homes in the state, and also an employee communication software that helps people through an app track whether their employees are happy in their day-to-day and whether they have to have their concerns resolved timely and appropriately delegated to have those concerns resolved. So it's an ease of use platform that we thought would really help people. They used it in Utah and it was successful, so we're copying them. So if you don't know if your community has already voiced an interest in this, I still am in need of several letters of support for both of these. All the letter of support has to say is, we think it's a good idea. It does not commit them to participation. They just have to establish for me whether the interest level is sufficient to meet the need for a grant. And then these are upcoming events. They're of course all listed on our event calendar at CHCA.org. Of particular interest to you probably would be the quality improvement and facility assessment leveraging that we're going to be talking about on April 18th. That will be co-taught by me and Courtnay from Telligen. Also, if you think that you have a new green wet behind the ears nursing home administrator that needs a once over, I do a 3-day course with many speakers of all kinds of disciplines virtually every 6 months for nursing home administration essentials, and that will be April 11th, 13th. So I welcome anybody who they need a once over to join us for that. Wound care conference will be in person at the Summit Event Center coming up at the end of the month, March 30th. And then since we've been talking about abuse reporting, we are hosting an in-person training in Colorado Springs at the public library there with law enforcement to talk about the requirements of mandatory reporting and processes on the legal side. So that should give you a good once over. Thank you so much.
Thank you. Great updates. I always learned so much from you, Jenny. Yeah. Thank you for bringing this information from CHCA to CMDA for our medical directors and providers. It's very valuable. Sounds like you got some grants pending. Good luck with that. How many letters of support are you still looking for?
I only need about 5 for the one for trauma-informed care to get me to the 80 threshold that they're requiring. But I need probably another 50 or so for the employee communication software.
Okay, cool, thank you. Any questions for Jenny? And I just had one more question, Jenny. Is there anything about the emergency rules that CHCA is especially on the lookout for or advocating for?
We are hoping to see a decrease in just the amount of rigor of COVID mitigation as it becomes less likely that cases are going to be monitored on a county level. We don't want any of the mitigation strategies to be based upon transmission levels because we won't have any way to mandate that labs report anything but positive cases. So we won't have a denominator that's of any value. I think CDPHE is very well aware of that and wants to adjust. to meet that, but there will be some language changes warranted for that. That'll be for masking, that'll be for issues of quarantine, for incoming admissions. It should kind of percolate through the mitigation guidance broadly.
Hello, this is Grant.
And we also are hoping that there will be some changes to the language around vaccine clinic requirements, which are currently required within 60 days of any FDA recommendation. But as you all know, I'm sure the ACIP recommendation is for an annual booster now. So for us to have a 60-day go every time they meet seems a bit not correlated to how they are proposing that it might be seasonal like the flu is what it sounds like. It just seems too rigorous to put into the permanent rules like that. So we're hoping to broaden that language a bit.
Yeah. Thank you for paying attention to those details for us. Well, if there aren't any other questions for Jenny, just pause for a moment. Okay, then we will move on to our final speaker today, who Jenny already mentioned, Courtnay Ryan with Telligen. Thanks for joining us today, Courtnay.
Yeah, thank you so much. Hi, everyone. Thanks for having me. And Jenny, great updates. My goodness, as many times as I get to talk to you during the week, I still write at least a page of notes every time. So thanks for sharing all of that. So I just wanted to share with you all, can you see my screen?
Yes.
Okay, thank you. A couple of our upcoming events that we have, just to make sure those are on your radar if you weren't already aware of it. So we are resurrecting a antibiotic stewardship tag buster project that we did prior to the pandemic. This is in collaboration with CDPHE and CHCA. So this will be a series focusing on antibiotic stewardship, really focusing a lot on the tracking and reporting around this. We'll be doing, as you can see here, it's going to start on April 7th and it will run through September 1st. It'll be the first Friday of every month for about 45 minutes long. We have some great speakers lined up for some of these sessions that'll take place. We're also going to support the Colorado nursing homes with doing a quality improvement project around antibiotic stewardship that they'll get to choose from. So really excited about this. The registration link is here at the bottom, and at the end of my updates, I'll just post a link to our Telligen event page, and you'll find more information about this there as well. The next event I wanted to share is our Wake Up Wednesday High Risk Medication Echo series. So for those of you that are not familiar with Echo, Telligen is a trained Echo hub, and the format of Echo sessions or learning activities is really where you have about 15 to 20 minutes of didactic information. There's a case study that gets presented, and then the forum is really open for peer-to-peer learning. So this is an Echo series that we started back in January. It runs through the end of April. It's every other Wednesday from 7:30 to 8 in the morning here in Colorado. So you can see the topics and the sessions listed here. On our website, you can go back and listen to any of the recordings from past sessions if there's something that sparks your interest. Our session tomorrow, we're really excited about having a speaker from the Eden Alternative who will speak to meeting the needs of elders. So really excited about this session. We've had some really great attendance and also, again, really great speakers. The next thing I wanted to share with you is that at the end of the month, at the end of March, the last week of March, we'll be hosting a week of NHSN office hours where we will go over how your nursing home can report the flu vaccinations in NHSN. So nursing homes have until the end of, have this, this data has to be entered no later than May 15th. And it's not in the same area that you've been reporting your COVID-19 data. So we've had a lot of questions coming in around this. And so we just decided to set up a whole week's worth of open office hours. They're at different times, as you can see down here, to hopefully meet the needs of everyone's busy schedule. So if you need some support around that, please join us for those. And then also, you're probably familiar with this. I hope everyone's familiar with this, but we're just wanting to continue doing our Blue Ribbon and COVID-19 Vigilance Award. So this is an opportunity for Telligen just to sing your names and praise you all for the amazing work that you do and recognize you. So this is a program that we have where we look at policies, processes, and ongoing staff education related to COVID-19 to prevent the spread of COVID-19. If you have staff vaccination rates for the completed COVID-19 primary series of at least 95%, and then if you meet the criteria for resident up-to-date vaccination rates of at least 80%, then you are eligible for this program. And so what that means is that you get a social media toolkit that you can, help recognize all the great work you're doing across the various social media channels like Facebook or LinkedIn or Twitter. And then we also send you a framed certificate, and then you're also posted on the website. So we hope to continue to see more Colorado nursing homes on this. We have quite a few already, but of course we'd love for all of the nursing homes to be on this list. And then we also have our Telligen's Best in Class. So this is kind of like an expansion of the Blue Ribbon. So in addition to those criteria that I just mentioned to be a Blue Ribbon recipient, if this kind of takes it the next step further around emergency preparedness, and also having 75% of your staff trained in infection prevention and control. So if you're meeting some of those criteria, then you receive what's called the Best in Class Award. So you'll also get a social media toolkit, a plaque, and then an opportunity to have your story featured on a national platform. So really excited about that. And we've also got some great Colorado nursing homes on this list as well. And then just a continuation of our weekly and monthly events that we will continue to offer for the foreseeable future. We do root cause analysis training every week, Plan, Do, Study, Act training every week, just to help support with quality improvement, skill building. Every week we have an Ask the Expert series, which alternates between our clinical pharmacy specialist on the team and our infection preventionist. So they talk on a focused topic and then open it up again for some peer-to-peer learning opportunities. We have our weekly Give Your Nursing Home a Boost session, our monthly QAPI 101 mini collaboratives, and then right after this, we're kicking off a two-part learning series of stepping into a new era with opioids, looking at the new opioid best practices from the CDC. So we have a session today, and then our second session will be on March 16th. So again, I'll post the link to our events page. You can find all of these there, or feel free to reach out to me anytime, and I'd be happy to share more details about any of these events. Thank you so much, Sing, for letting me share those.
Appreciate it, Courtney. Does anyone have questions for Telligen? Courtney? Those sound like really amazing programs that are coming up for our facilities. Do you know, Courtney, how many facilities in Colorado have one of those COVID blue ribbons?
Yeah, I think the last that I checked, which was probably about 3 weeks ago, I think we had 117.
Very cool. Great.
Yes.
Awesome.
The list of all of them that received it is on our website.
Oh, okay. Good. Thanks for that link in the chat box. Appreciate it. Well, I think today I got a lot of resources that are sure to be helpful for our facilities and for our staff in all the initiatives that we're trying to implement in our facilities. So thank you, everybody. Appreciate all the information from our great speakers. And if Courtney, Jenny, and Elizabeth, you have the slides are okay to share with our members, please email them to me and I'll make sure we send them out. Wow. And of course, just one more reminder, because we can't remind you enough, we'll have our CMDA annual conference on April 28th. And so we would love for you all to get registered and register your teams so we can all hang out together at the conference. Thank you very much for joining today's monthly meeting. We'll see you next month. Bye-bye.